Good morning, and welcome to the Overdose Reduction Technical Assistance Center's 2020 Symposium, Building Bridges, Community Partnerships to Mitigate Opioid Overdoses. We have a fantastic morning planned for you, and we are really excited that we have so many people on the line. Thank you for sharing with us where you're from this morning. That's been fantastic to watch. My name is Amanda Mihalko, and I am the Program Director for Community Health Initiatives at the University of Pittsburgh's Program Evaluation and Research Unit. Before we officially begin, I did want to share with you that the symposium will be recorded today, including the chat and the question and answer sessions. And now I'd like to introduce the Dean of the University of Pittsburgh School of Pharmacy, Distinguished Service Professor, and Gordon J. Vanscoy Professor of Pharmacy, Dean Patricia Kroboth. Dr. Kroboth has led Pitt Pharmacy, of which the Program Evaluation and Research Unit is a part, to become a leader in education, a research school of distinction, and an innovator in the practice of pharmacy and in emphasizing the pharmacist's role in the community. We are honored that the Dean could be with us this morning to provide a welcome to our symposium. Dean Kroboth.
Morning. Good morning, everyone, and thank you, Amanda. I want to thank each and every one of you for being part of this very first Overdose Reduction Technical Assistance Center Symposium. As Amanda said, I am the Dean, and my name is Patricia Kroboth. I congratulate you on the outstanding work that you are doing, and I have to say how proud I am that the University of Pittsburgh is such a critical part of this session and has hosted it for so many years. Now the question is, why would I say we've hosted for so many years if this is the first ever? And that is that many of you may have been at our annual Allegheny County Overdose Prevention Conference series over the past number of years. And today is a continuation of that wonderful time in our year when we come together to learn from leaders of innovative programs, to identify emerging issues, and to celebrate the progress towards recovery and health for our community members. In 2018, Allegheny County experienced its first reduction in overdoses since 2013. Following that milestone, this year's theme, Building Bridges to Mitigate Opioid Overdoses, encourages us to explore how we can work across organizations, sectors, and counties to help place individuals in need into treatment and to help those in recovery build a healthy and happy life. This means that we must strive to implement innovative, collaborative programs to improve access to care, engagement and retention and treatment, and recovery support. Today, we're going to be hearing from Pennsylvanians who've taken the initiative to forge innovative programs designed to support and sustain healthy communities so that we might learn from their example and expand upon their efforts in our own work. I hope that these presentations today will enrich your professional and personal perspective, renew your passion for solving the complex problems of reducing opioid use disorder and overdoses among members within our communities. At this time, I'm going to ask Amanda Mihalko, Program Director of Community Health Initiatives at PERU, to give us an overview of today's topics and move us into the symposium. Again, I congratulate you for all the wonderful work that you are doing and wish you the very best as you continue this incredibly important work that truly does save lives. Amanda?
Thanks, Dean Kroboth. We really appreciate you being here this morning. And absolutely, as you can see on the screen, we do have our agenda for the day up. We're starting with our welcome and introductions, and then we'll be moving into our first presentation, Integration of Physical, Mental, and Behavioral Health by Dr. James Schuster. And we're excited to have Dr. Schuster with us this morning. Afterwards, we'll take a quick break, and we'll come back for our second presentation of the morning, Bridging Gaps, Public Health and Public Safety. And we look forward to hearing from Colleen Hughes, the SCA at the Westmoreland Drug and Alcohol Commission. Very excited about that. We do have, before we dive into those presentations, we wanted to review a few housekeeping items. Continuing education credits are available for a number of professions. You can see them here. Registration and evaluations are required. We will send via an email an overview of the symposium, as well as instructions for next steps for CEs. The links will also be available in the chat and on the website overdosefreepa.pitt.edu. And again, we'll provide all of that information via email as well. Please remember, our symposium is being recorded. That includes the chat feature and the questions and answers. We'd like to remind you that you will stay muted throughout the symposium, and you can submit your questions through the chat for the question and answer session. And folks have been using the chat beautifully this morning, so let's try to keep that engagement up. We will include a link to the evaluation in the chat at the conclusion of the symposium. We'll also follow up with an email after the event. And now I would like to introduce our first presenter, Dr. James Schuster. Dr. Schuster is the Associate Chief Medical Officer and Senior Vice President, Medical and Behavioral Services for the UPMC Insurance Services Division. He provides oversight to medical staff as well as leadership for integrated medical and behavioral services and the UPMC Center for High Value Healthcare. Dr. Schuster has served in key clinical leadership roles at Community Care Behavioral Health Organization and UPMC Health Plan over nearly 2 decades. He has led teams at the UPMC Center for High Value Healthcare that have secured several awards from the Patient-Centered Outcomes Research Institute and other funders focused on integrated care, shared decision-making, and medication-assisted treatment. He is a clinical professor in the Department of Psychiatry at the University of Pittsburgh and is board certified in psychiatry and in the subspecialties of geriatric psychiatry and addiction psychiatry. Without further delay, I would love to turn it over to Dr. Schuster.
Thank you for having me today. I really appreciate it. As Amanda was saying, I work at both community care and the broader UPMC Insurance Services Division. And this idea of integrated care and addressing wellness in people with behavioral health disorders has really been the focus of my career for over the past decade. So I really appreciate the chance to talk with you all this morning. If you go to the next slide, please. So as I was thinking about talking about integrated care and how we help people who have behavioral health and physical health disorders, it struck me that especially at this time, we really needed to talk about the impact of both racism and stigma and how those impact folks with substance use disorders, not only around treatment of their substance use, but also around treatment of their physical health disorders and of other challenges that they're working with. And as you'll see as I walk through I think some of the next material, that the impact of these factors is so systematic and pervasive that it's really not possible for us to be successful without addressing them. So I did want to touch base on those this morning. Then I also wanted to talk a bit about the impact of concurrent physical health concerns for individuals with substance use disorders, and why it's important for us as behavioral health professionals to address physical health issues with the people that we work with. And then I wanted to also then talk about some strategies that can address concurrent physical health and wellness challenges in both primary care settings and in specialty substance use treatment settings. And I feel like this topic is especially relevant for a conference put on by PERU, since engagement of physical health practitioners has been such a strong focus of PERU over now probably at least a decade as well. All right, if we go to the next slide, please. So for those of you all who are not from southwestern Pennsylvania, I did want to just kind of tell you briefly about UPMC, where I'm from, where I work. So UPMC is the second largest provider-owned group of insurers now in the country. The largest is Kaiser, and UPMC is the second largest. But unlike Kaiser, which is distributed nationally, UPMC is really primarily focused on Pennsylvania. The UPMC does have some facilities as well in Maryland and New York, but the vast bulk of the business is both from the provider side and from the insurance services side is within Pennsylvania. There's several key areas that are focused. There's commercial plans, Medicare plans, Medicaid, behavioral health, which is community behavioral health organization, and a number of employer services, which are go under the acronym of Work Partners. For those of you outside Pennsylvania, Pennsylvania has a very, I think, unique and progressive model for management of behavioral health services for those with Medicaid, which is that the behavioral health services are really, I'm oversimplifying this for purposes of time, but the Medicaid behavioral health is significantly managed by typically the behavioral health human service offices at the county level, which also manage children and youth, aging services, forensic services, and so on. So this was really I think an early attempt to integrate behavioral services with what we now call social determinants of health. Community Care, or CCBH, is a company that partners with 41 of the 67 counties in the state to manage those services. If you go to the next slide. So this just gives you a graphic of the different companies involved in the UPMC Insurance Services Division. You can see down here is Community Care in the kind of bottom left. And then there are a number of other plans across commercial, Medicare, Medicaid, and CHIP, dental, and vision. If you go to the next slide, please. This just gives you a map of the areas where UPMC for You, which is the physical health Medicaid plan, where that's based. The colored counties are where it's based. The state recently did a reprocurement and has announced that UPMC for You will eventually be allowed to expand throughout the state. If you go to the next slide, please. And these are the 41 counties that Community Care partners with around behavioral health services for individuals with Medicaid. All right, next slide. Okay, so again, these are the key themes that I want to touch on this morning. The first is that really racism is implicated in all of the healthcare challenges that we face, including the ones that we're talking about this morning. The second is that stigma regarding substance use disorders creates additional barriers for individuals with substance use in terms of getting adequate care. The third is that there are several evidence-based strategies for addressing physical health concerns for individuals with substance use disorders. But as you'll see, racism and stigma limit their impact. So we definitely want to pursue the evidence-based strategies, but we really have to concurrently focus on racism and stigma to likely have this degree of success that we want. And the last is that we really, again, need really multi-systemic approaches to work through the issues that we face. By the way, one thing I meant to say in introduction, but forgot in the context of my microphone challenges, was I really wanted to give credit to Kara Renzelli. Kara works with me in the insurance division as the director of our substance use related work. And she really did a great job pulling this material together. So I wanted to appreciate my gratitude to her. Next slide, please. So I wanted just to touch base on racism in our healthcare. And unfortunately, there's a history of this both through an extended period of our prior history and evidence that it continues today, less consciously, but still persistently. So I wanted to just give a couple examples of the impact of racism on medicine throughout our history. And this is important not only because of the historical impact, but this history really, I think, affects how people of color often feel about our medical systems and systems of care that they encounter today. So the issues of racism in medicine really have, again, unfortunately extended throughout our history, really back, no surprise, especially during slavery. African-American slaves were often used as experimental subjects in medical experiments during the pre-Civil War period. Many surgical techniques were initially tested on slaves, and many suffered through experimentation until they either got better or they died. By the way, on this slide, you'll see there's several references. There are references throughout the slides, and certainly Amanda or others can certainly share the slides with you post presentation today. Next slide, please. So the best known example of racism in our healthcare is the Tuskegee syphilis study. So this was approximately 400 Black men in Tuskegee, Alabama, or near Tuskegee, who had syphilis, were enrolled in this study to study the course of illness. They were informed that the purpose of the study was to understand the course of the disease, but they did not receive adequate treatments as they were developed. In particular, in the 1940s, when it became clear that antibiotics would help to treat syphilis, they were not provided that treatment. So they were really grossly mistreated as part of this study, which continued until 1972. So it continued until into the lifetimes of many of us who are on this call today. Next slide, please. There are other examples of racism in our healthcare. Again, in the 1970s, many American Indian women were sterilized without their permission. California had a eugenics law. This was the kind of disgusting theme that was often referenced particularly in the 20s, 30s, somewhat in the 40s, that said that people's genetic heritage was kind of the be-all and end-all of their outcome, and that people should be treated differently based on their family or other history. And there was a high rate of Latino men and women who were sterilized under this program in California. Next slide, please. So, now turning to more recent data about the impact of racism on our healthcare. So one is that individuals who are Black have higher death rates. And this is over a period of 20 years, includes premature death rates from stroke and coronary artery disease. And there are, one of the questions that people often raise is how much of this disparity might be caused by disparities in underlying socioeconomic conditions or social determinants of health, since those clearly play a role in people's health outcomes. But there have been studies that have tried to control for those variables. And what they demonstrate is that the death rate is still higher for Black folks than others, even when you control for socioeconomic variables. And there have been other studies which demonstrate that Black individuals who receive care from Black healthcare professionals have a better outcome than people with the same illnesses and underlying conditions who receive care from white individuals. So I don't think the conclusion of that is that the white caretakers are intentionally mistreating anyone, but it just, I think, demonstrates the pervasiveness of stereotypes and unconscious thinking, in all of us. Also in the US, infant mortality rates for Black women are more than double for those of white women. And homicide rates are almost 7 times higher for Blacks than for whites. So clearly the impact of racism is extensive. Next slide, please. There are also differences among other racial and ethnic groups. Homicide rates are also significantly higher for American Indians and Hispanics than whites. Motor vehicle death rates are higher. And historically, on the flip side, we've noticed that suicide rates are higher for whites. Next slide, please. So in Pennsylvania, we see similar trends. If you look, you see that if there was a survey done, this was a few years back, asking individuals what their healthcare condition was. And you can see that 27% of Black individuals said that their health status was fair or poor, 23% of Hispanic, and 16% of white individuals. Next slide, please. In Allegheny County, the numbers or the trends are unfortunately similar. There was a study done 2019 looking at the city of Pittsburgh and found that maternal related deaths are twice as likely among individuals who are Black in Pittsburgh as compared to women who are white. And if you expand that to Allegheny County as a whole, the mortality rate is even more disparate. And the study unfortunately found that we don't compare very well even to other similar metropolitan areas in the United States. So that our trends in Allegheny County, our disparities are greater than in many other parts of the country. Next slide, please. So I wanted to turn then to the impact of racism on substance use disorders. And what we found was that, or what was, not what we found, but what others have found, and this was a study from 2016, that people who are Black or Hispanic are less likely to complete treatment than whites. This disparity was especially evident among those who use alcohol or amphetamines. For Hispanics, the disparity was especially notable among those who use heroin. And there was a greater difference between blacks and whites than between Hispanics and whites in general, although there were differences with both groups. Next slide, please. In terms of treatment of substance use disorders, women are less likely to access treatment compared with men. So it looks like there's some disparity based on sex as well as race. And another study found that women who had an opioid overdose were significantly less likely to receive naloxone, Narcan, from EMS than men. So it looks like, you know, we need to be cognizant of disparities that are based on sex as well as those that are based on race. Next slide, please. If you look at the dean in her opening talked about the recent flattening of overdose deaths in Allegheny, and it's true in some surrounding counties as well. In Pennsylvania in the last couple of years, but the rate of increase prior to that had been greater among Black populations than the general population. And in particular, deaths related to synthetic opioids. And then the research indicates, and our own numbers indicate from the insurance division indicate this as well, that Blacks with opioid use disorders are less likely to access medication-assisted treatment than whites. So, you know, how much of that is because, you know, they're less likely to present for treatment, or they're less likely to be offered treatment? You know, the degree of impact of each of those is hard to tease out, but they clearly are less often treated than whites. Next slide, please. Clearly, one of the factors, and this is true really across medicine, but it's certainly true in substance use disorders as well. One of the factors is a shortage of Black and other minority physicians and clinicians. You know, one of the, when focus groups have occurred, and this is true across many medical settings with minorities, to get a sense of what drives some of their lack of trust or engagement with systems of care, they report that part of the issue is that the clinicians don't look like me. And, you know, to backing up their that feeling from the patients is, again, the evidence that suggests that treatment by someone who does look like them may result in a better outcome. But there's a, you know, as or greater shortage of Black and other minority clinicians in substance use disorders as there is in other areas of medicine. Next slide, please. So again, we need to, I know we're all looking at strategies to address racism within our organizations, and you know, we certainly need to continue and redouble those efforts, and they will impact our ability to successfully address physical health and wellness issues as well. So I wanted to turn though now to you know, the focus on physical health issues. And I wanted to talk about a few different themes. The first is the current status of addressing substance use in primary care settings. The second is strategies that we can use to enhance identification and referral of individuals from primary care settings who have concurrent substance use disorders. The third is I do think there are a number of opportunities for us as behavioral health professionals to enhance the attention that's given to physical health in substance use programs. And I think in the same way that PCPs often have felt uncomfortable addressing substance use disorders, there's been a concurrent challenge with behavioral health practitioners addressing physical health problems and having a sense of discomfort with that. But the people we treat in our substance use programs have many often physical health disorders. So I think it's important for us to identify those and again, to try to help make sure people get engaged in appropriate care. And I do think there are a number of opportunities for us to address these issues in Pennsylvania. Certainly, we've had strong support from county departments of human services, the county's SC single county authorities with a number of these themes, and the state departments of human services and the Department of Drug and Alcohol programs have also been very interested and supportive of this work. So I do think, when you look at resources provided to community-based mental health and substance use programs, there are never enough for the needs that we have, but Pennsylvania is, compared to most states, well-funded in the public arena. So we do fortunately have resources to help us address these issues. Next slide, please. So I wanted to take a minute just to touch on what are the serious health issues related to substance use. Certainly, many of you are familiar with these, but I wanted to just highlight them briefly. The first is cirrhosis, typically related to alcohol intake, and unfortunately frequent issue. And this is basically disease of the liver related to the alcohol use, which can certainly be fatal. The second is hepatitis C, which is contracted most commonly through intravenous drug use. Third is there are a number of cancers related to substance use, especially there are a number of cancers related to smoking and alcohol use. And we think about cancers in the oral cavity or lung cancers related to those. But really there's evidence that many cancers, even in more remote parts of the body, prostate cancers, colon cancer, and so on, are also related to significant substance use. And actually any alcohol use seems to be associated with an increased cancer rate. It's a modest increase, with what we typically talk about as moderate use, or use that doesn't qualify for a DSM diagnosis. But really all use seems associated with some increase in cancer risk. There is cardiovascular risk, especially related to smoking, but also related to cocaine, amphetamine, and other substance use as well. There are infections of the heart, endocarditis, which seem to be related especially to intravenous drug use. There's certainly danger of death or serious injury from accidental overdose. And there's a strong correlation between many mental health disorders and substance use. So there are, when I know that when people present to a substance use treatment program, we certainly first think about treating their substance use. But you know, with the exception of overdose from intravenous opioid use, the likely causes of death are typically, you know, physical health disorders related to the chronic use rather than directly to the use itself. So it's obviously critical to address individual substance use, but I think it's also critical for us to evaluate and really work to engage individuals in addressing their concurrent physical health problems. Next slide, please. And there, you know, one of the advantages that we have in terms of our background in treating substance use disorders is that we have developed significant skill sets focused on engaging people in treatment of their substance use disorders, especially motivational interviewing and associated strategies. And we can really use these same strategies to engage individuals in addressing their physical health problems. So, as you know, many of us have spent our careers really working to implement strategies and help our patients learn strategies that allow them to manage their illness, whether that be abstaining from drugs, changing behaviors to avoid triggers for drug use, you know, learning how to changing thinking patterns around substance use. So we've learned lots of behavioral strategies to help people address their substance use disorders. And really the very similar strategies can be used to help them address their other physical health challenges. So, you know, among people with behavioral health disorders generally, the shortened lives are due to social determinants of health, you know, really often the impact of poverty, smoking, and obesity. And so the strategies, again, that we use to help people with other substance use disorders can also be used to apply to these issues. Next slide, please. So I want to talk a little bit about some different programs or approaches to help. One is integrating behavioral health evaluation and coordination in physical health settings, especially primary care. The primary evidence-based approach for depression and anxiety is one called the collaborative care model, in which a behavioral health practitioner is embedded in primary care settings and actually, for most patients identified with depression and anxiety, partners with the PCP to offer treatment. Rather than referring patients out to specialty care. For substance use, there's been a different model developed, and I'll talk a little bit more about that, ESPERT, which is focused on screening, certainly for some patients, brief interventions, but then for people who have significant disorders, referral and treatment in specialty settings. And I think there are a number of reasons that there's somewhat different approaches for, not totally different for sure, but somewhat different approaches for mental health and substance use, partly related to the fact that, you know, PCPs are often now comfortable, at least offering some, or at least more comfortable offering some treatment for depression and anxiety than they are for substance use. Also want to talk a little bit about integrating of physical health evaluation and coordination in behavioral settings. You know, think about care management programs that address physical and behavioral health issues, and try to think about what indicators we want to look at to understand the impact of our work. Next slide, please. So I just wanted to put this up here as a reference. this was developed by the American Psychiatric Association several years ago as a model to talk about different levels of integration between physical and behavioral health, with the idea being that a fully integrated practice, is kind of an optimal outcome. In some ways, that's certainly true. I do think that this chart kind of oversimplifies a bit these different levels and distinctions between them. It's certainly possible for people to get good, well-coordinated care with, I think several of these models. But I think that I wanted to show this because it does, I think, nicely kind of define some different models, and it is a good reference to use. I wanted to say I would use it as a reference rather than gospel. But it has been widely circulated, and people often refer to it. So I wanted to make sure that that you all had a chance to see this. Next slide, please. So, when we talk about treating or identifying substance use treatment in primary care, so we talk about integrated care, there certainly is, stigma definitely plays an impact in primary care's approach to substance use. This was a survey, it's now from 20 years ago, and I apologize it's that old. We did look for a more recent one, but we're unable to find one. If anybody knows of one that would be, and would like to share that, that'd be wonderful. This is, I'm sure that these numbers are better than they were 20 years ago, but you can see that, at that time, almost all PCPs were at least not very familiar with, didn't screen for even alcohol use, much less other substance use disorders. And that most of the patients with substance use disorders said their primary care physician didn't address it even when they were aware of it. So again, these numbers are undoubtedly better now, but they are undoubtedly still have a ways to go. And I think, we all have extensive anecdotal feedback from the patients we work with that certainly primary care physicians are not fully engaged in addressing substance use at this point. Next slide, please. This is some additional information. This study is only from a couple years ago, a qualitative study of primary care providers, staff, and patients. So providers agree that substance use screening was important, but they only did it if the patient presented with a problem that triggered a concern about substance use. So if people presented with a liver problem or other issues that might be related to substance use, people asked about it. Our physicians asked about it, but they didn't do universal, by and large, did not do universal screening. They felt like they didn't know what to do to address substance use disorders. Medical assistants reported that they were not likely to screen because they felt like even if they had a positive finding, they didn't think the PCP would necessarily address it. And that even when behavioral health providers are available in a medical setting, their time and resources were limited. So again, undoubtedly, the stigma and access to screening and intervention with primary care is better than it was 20 years ago, but we still have a ways to go for sure. Next slide, please. And just to give you a sense of the limited provider resources, there are two primary certifications for physicians to receive around addictions. One is a certification from the American Society of Addiction Medicine, which typically will certify physicians other than psychiatrists. They'll certify psychiatrists too, but psychiatrists have a special certification they can get from the psychiatric board organization. So there are under 2,000 physicians nationwide certified by ASAM, American Society of Addiction Medicine, and about another 1,300 certified by the addiction psychiatry boards. So it's about 3,000 docs across the entire country who are certified in addiction. Not that there are undoubtedly many more physicians who are comfortable and competent for sure in treating addictions, but it's still undoubtedly a small number compared to the need. And this is especially true in rural areas. Next slide, please. So the primary intervention that's been developed and implemented with primary care is one called screening, brief intervention, and referral to treatment, or SBIRT. So, and it's has extensive evidence suggesting that it's effective at screening, early intervention, and getting people into treatment who have substance use disorders. And the data suggests that routine screening is critical. Almost a quarter of primary care patients age 18 and older are misusing alcohol or other drugs. And about 40% of emergency department patients. So it's, as physicians, when patients come in, we screen for many disorders, right? We screen for pulmonary disorders, cardiac disorders, urinary disorders, etc., neurologic disorders, but undoubtedly a higher percentage of the people we see probably have substance use disorders than almost any other disorder that they come in with. Probably the only thing that's higher probably is cardiovascular related disorders, including hypertension. So the substance use disorders are common, but they're still not universally screened for. And SBIRT is an effort to address that. And with some significant success, I think, to date. Next slide, please. There is research that suggests that SBIRT contributes to reductions in healthcare costs while increasing substance use treatment engagement. Just parenthetically, I have to say there's extensive research that suggests that screening for and engagement in substance use treatment reduces costs, not only healthcare costs, but especially other social costs. Things like reducing missed days from employment, reduced family conflict, reduced problems for children, reduced housing instability. So there clearly are reductions in many different areas. I did want to just say that that this is probably not as true for people with opioid use disorders because of around healthcare costs narrowly, because the cost of the treatment, in particular buprenorphine, Vivitrol, are substantial. So it absolutely doesn't mean that we shouldn't redouble our efforts to treat individuals with opioid use disorders. It's just we don't have the same degree of cost savings data to accompany that. SBIRT can be used with a variety of age groups, including anyone really from adolescent up. Next screen, please. Next slide. So who can administer SBIRT? Really anybody. Anybody who works in a healthcare setting can be trained to administer SBIRT. It's really a relatively brief screen. So really anybody, including I think really including the medical assistants, can administer the questions. Where can it be administered? And again, the answer is really pretty much anywhere. including places outside of traditional medical settings, including pharmacies. And I know PERU has done some work with pharmacies around administration of Espert and demonstrating the positive impact it can have. Next slide, please. So there is training for individuals to get them engaged in administering Espert. And there are three kind of broad aims, right? The first is early identification to really help people get engaged in treatment and to reduce escalation of the disease that would lead to emergency department visits or use of more intensive services. The second is really to improve measures of initiation and engagement in treatment. So this is, and it's not for the sake of improving the measures, but it's because people with substance use disorders, as you all know, don't do well unless they're really engaged in treatment for a period of time. HEDIS is an acronym for measures developed really by insurer-related entities and in collaboration with CMS and other organizations. And they've developed some measures for initiation and engagement of individuals in substance use treatment. So, do people come back for a couple visits within the first 30 days? And do they stay in treatment at least for 90 days? And then the third goal really is to promote the recovery of the individuals identified. Next slide, please. We had a award recently that it's getting towards the end, but not quite over yet, at the UPMC Center for High Value Healthcare, which is a research and grants group that sits within the insurance division, has partnered with DDAP to work to address substance use disorders, especially opioid disorders, in 4 rural counties in Pennsylvania. We really work to reach out to primary care physicians, and just in those 4 counties, we were able to reach 300 providers, at least to make them aware of online Espert training, and almost 200 of them completed the course. So I'm sure not all 200, perfectly implemented the training, but it is possible, even using remote learning, to spread this screening and engagement strategies. Next slide, please. And I did want to note, we're here at a conference sponsored by PERU, and PERU has really been a leader in Espert implementation, especially in Pennsylvania, but also in other states. And their work around Espert has included work with emergency departments, PCPs, behavioral health practices, specialty medical settings, pharmacies, and EMS services. So it's, as you can see, it's possible to implement this in many different types of provider settings, and it's been successfully done in Pennsylvania. Next slide. So certainly one of the opportunities, one of the key models that facilitates implementation of Espert is a model called the patient-centered medical home. And this is a model now developed probably initially about 15 years ago. And the idea was to enhance a traditional primary care setting so that it could provide more comprehensive patient care to enhance outcomes. So there are a number of strategies that PCPs need to implement in order to get patient-centered medical home certification, including things like extended hours, offering other strategies to increase access to care, and offering a broader range of services than just the PCP within the primary care setting. Certainly one of the themes of the patient-centered medical home is enhanced attention to behavioral health disorders, and certainly Espert fits within that. And as you can see, about 13,000 practices have attained this status in the US. It doesn't mean that they've all implemented Espert, but Espert's certainly consistent with that, and the model helps to support that. So there certainly are many opportunities for us to help expand Espert. Next slide. You know, the goal again for the patient-centered medical home is to really reduce fragmented care and better manage chronic conditions. And the research suggests that the model is effective, both in terms of reducing admissions and increasing screening for a number of, you can see, medical illnesses, cancer, diabetes, hypertension, and undoubtedly for substance use as well. Next slide, please. So in addition to increasing the attention to substance use in primary care, primarily through the use of an expert model, again, there's opportunities for us to increase attention to physical health challenges in behavioral health settings. And over the past decade, community care has worked with providers, family members, patients, and others to develop what we call a behavioral health home model. So the idea is, you know, in the same way there's a patient-centered medical home model in primary care, we really wanted to create a similar model for behavioral health settings. And the goal was really to enhance the capacity of behavioral health providers to serve as a health home that could help with comprehensive care management across all illnesses, really help coordinate care and promote, you know, general good health and wellness practices, and help link patients to community resources as well as other medical resources. Next slide, please. So we created this model we called Behavioral Health Home Plus, and it includes creation of self-management toolkits for individuals around things like smoking, weight management. We trained case managers and peers staff in wellness coaching, which is really motivational interviewing strategies applied to physical health and wellness. We used a learning collaborative model, you know, really a structured dissemination model to engage the practices. And we also help the providers learn how to use a health registry and track individuals' progress over time. And we also supported the placement of a nurse focused on wellness and physical health in the behavioral health settings. Next slide, please. We were able to fortunately receive some funds from PCORI to evaluate this model. And we evaluated 11 different practices. We randomized practices to either work with individuals using self-management strategies, or we place nurses in the practice to help increase the focus on physical health disorders, especially the focus by the care managers and peer specialists. Next slide, please. And what we found was that both approaches led to significant improvement in engagement in primary care and improved what's called patient activation in care, which meant that the patients became more aware of their physical health needs and felt like they were more empowered to address them. Next slide, please. We also did some additional analysis to see if these strategies impacted the total cost of care, and we found that they did. One of the caveats I wanted to mention, and this has been true as well for other strategies that have looked at behavioral approaches to address the cost of overall medical care, which is that in the first year, the costs don't go down, probably because people are getting more engaged in addressing previously unrecognized medical problems. But the total costs do start to go down in the second year, and that was what we found as well. So in the second year, there was about a 15% decrease in the total cost of care. There was a significant decrease in inpatient use. You saw on the former slide that there was an increase in use of primary care and other community-based physicians, but there was decreased inpatient use. And there was also even some decreased behavioral health use, even though that wasn't the focus of the study, of the intervention. The focus was to enhance engagement and care of physical health problems, but it did decrease behavioral health costs, including the case management cost as well. Next slide. So after that was completed, we were fortunate and received a second award from PCORI to disseminate and expand implementation of the model, and we worked to implement it in several opioid treatment programs. And for those of you who are not in the substance use business, that's an acronym for programs that offer methadone treatment. Those are folks, typically people get into methadone treatment if they've had a long history of use. So they tend to be a little bit older than most patients who seek substance use treatment. And they also have a longer history of substance use, so they're more likely to have developed concurrent physical health problems related to the substance use. And they're also less likely to be engaged with their PCPs. Next slide, please. So the goal was to really offer some focus on health and wellness in locations where people are going routinely. You know, if people are in methadone programs, they have to go frequently to the methadone program. So it seemed like an optimal place to work to engage them in addressing their physical health and wellness problems as well. Next slide, please. We did use a learning collaborative model. Community care did support placement of wellness nurses in the community care in the counties that we work for, supported placement of wellness nurses. And the goal was really to try to make sure that they got better engaged with their PCPs if they had one, or link them to one if they didn't, and to help the patients really identify what their own goals were, and to use really a motivational interviewing approach. So, you know, they might not care about, you know, how many cigarettes they smoke a day per se, but they might be frustrated by shortness of breath that limits their ability to go places or to engage with their family. So the goal would be to really try to enhance their ability to walk farther or to engage better with family, and then decreasing smoking would be a strategy to help them reach their goal. Next slide, please. And you can see these are the goals that individuals chose. You know, you can see that the ones that they chose were mostly, or were certainly not primarily ones that we might choose as healthcare professionals, you know, which would probably be things like smoking cessation or taking your medications. Those were included, but certainly things like improving diet, increasing physical activity, sleeping better, those types of issues were also identified. Next slide, please. So we implemented this in 7 different opioid treatment programs. There were 108 staff trained across those programs in wellness coaching. And even within the first 6 months, you can see that almost all of them had a physical health assessment completed, had established a wellness goal, and about 70% of the staff and the members felt confident in their ability to address these physical health and wellness issues. So we thought that that was really a great start for the first 6 months. Next slide, please. There's certainly also, as I noted at the beginning earlier in this talk, there's significant support from the State Department of Human Services focusing on integrated care. The department is currently providing financial incentives to managed care organizations, both physical and behavioral, to make sure that individuals with concurrent physical and behavioral challenges have integrated care plans, which reflect integrated strategies across physical and behavioral. That includes completing assessments, making sure people get connected to services, providing education, and evaluating, and so the incentives are tied to things like reduced rates of hospitalizations and readmissions. So there's not only technical assistance available, but there are also financial incentives for the health in Pennsylvania Medicaid. The program is called Health Choices for the Health Choices insurers to address these issues. Next slide, please. I did earlier mention HEDIS, which is essentially the quality of care metrics used by insurance companies, and these are also used to grade insurance companies. You know, you may have seen things for Medicare plans where they're rated 5 stars, 4 stars, etc. Or you may see that commercial plans or Medicaid plans have received ratings from what's called the National Council on Quality Assurance, NCQA. Over the last several years, at least some substance use quality of care metrics have been added to these, the spectrum of items that companies are evaluated on. So you can see one is whether or not there's a 7-day follow-up visit after an emergency department visit for alcohol or other drugs. And then under initiation and engagement, again, there's measurement of whether or not people get started in treatment for alcohol or other drugs after the problem's identified, and whether or not they remain engaged in treatment. So there's certainly further to go in terms of quality metrics around substance use, but it is now you know, at least an area that's recognized as important, and there is ongoing work underway to really try to add additional metrics over time. Next slide, please. Just to give you a bit more information about what these are, the follow-up after emergency department use is, you can see percentage of emergency department visits who have a 7-day follow-up visit. And you can see that the follow-up visit can be telephonic or online. So I know particularly with COVID, you know, many of us have moved to providing extensive care via telephone or other online strategies, and those visits count in this metric. Next slide. And the initiation is, you know, really whether people have any kind of visit during the first 14 days after identification of the problem. Next slide. And the engagement is, you know, whether they remain engaged in treatment beyond that initial month. And again, telephonic visits and online assessment can count as part of these ongoing treatment. Next slide, please. So I do think that, you know, these metrics are kind of, as well as the focus on whole health in this conference today, really exemplifies that we're all becoming more aware of the need for, you know, to address both physical and behavioral health issues in whatever setting people happen to present for care within. And the goal is really to you know, use quality metrics and financial incentives to really try to help support this work over time. Next slide, please. So in summary, there certainly are, you know, intentional efforts that we all have underway to address racism and stigma, both within our own organizations and in the larger communities we sit within. Undoubtedly, those are, you know, even in many ways that are unconscious or not visible to us at first look, undoubtedly impacting our care. So it's critical to continue to focus on those. There is evidence that involving multiple stakeholders, including primary care physicians and other people in the community, can really reduce disparities and improve outcomes. And there are evidence-based targeted models that can really help support this work. All right, so I'm a little bit past 10, which was, I think, supposed to be my cutoff. So I'll stop presenting here, but I'm certainly happy to take questions.
Perfect. Thank you so much, Dr. Schuster. This was a fantastic presentation. As a reminder to our attendees, if you do have any questions for Dr. Schuster, you can place them in the chat. And while you're doing that, I did want to share, someone during the presentation had asked if we would be sharing the presentations, and our plan was to have those available as a PDF on Overdose Free PA. And so we will make sure there's a link to that in the email you receive after the symposium. I do have one question to start us off, Dr. Schuster, and that is, what do you think is the biggest obstacle to integrating more substance use disorder friendly work into primary care practices? And the attendee had a follow-up question, which was, any suggestions on how to overcome this obstacle?
You know, that's a great question. There certainly are a number of practical issues, you know, which we alluded to, and we didn't get into great detail, but, you know, there are issues around time, around payment, around, knowledge, around presence and availability of substance use professionals. But I really think the greatest obstacle still is stigma, probably a lot of it unconscious, and concurrent anxiety by primary care physicians in dealing with substance use. PERU, the UPMC, and many others have done extensive work in Pennsylvania, as well as many others in other states, to really try to embed behavioral health services or enhance accessibility to or engagement in behavioral health services in primary care settings. It's, although it's not really a disorder different than anything else in terms of complexity that primary care physicians deal with, there's still great hesitation on their part in doing it. I briefly spoke about work that we've done, and PERU has done similar work to try to engage PCPs in treating substance use. And you can see from the data I showed, and PERU has data and other people have published data, it's certainly possible with some systematic effort to engage folks in making screening part of their routine. But it's hard to get primary care physicians engaged in going beyond that. One of the areas in which there's been a great deal of focus has been really trying to get primary care physicians engaged in prescribing buprenorphine and Vivitrol, even for patients who are already in their practices, who are relatively stable. So not necessarily starting people on the treatments, but even continuing the treatments. And there's only a minority of physicians, primary care physicians, who are interested in that. And then typically it's only if there's significant additional resources brought to their practice. But even with these additional resources, the majority of PCPs have not been enthusiastic about that. So I think a lot of it is really conscious and unconscious stigma, and I think we've all been working on a number of strategies around stigma in our communities for years, which primarily focus on both an educational component and an experiential component, to actually allow people to talk with folks with substance use disorders. So Dr. Pringle and others, I'm sure, have other suggestions, but I think at least a key one would be to really reach out to PCPs who your patients work with, to provide education about your services, to help them develop strategies to support screening and brief referral and easy referral to you when they do identify individuals. And I do think it's, a lot of it is kind of one-to-one attention and support that will really help us address stigma over time.
Thank you, Dr. Schuster. That's a fantastic response. I appreciate it. There's another question here in the chat. An attendee wanted to know, did home health agencies have any problems with managed care billing for their in-home visits that you mentioned?
So I actually wasn't referring to home care. So I realized the acronym's a little confusing. But I was talking about a behavioral health home, and what this is really a traditional behavioral health provider, which could be a methadone treatment program, case management agency, other behavioral health provider, and really trying to increase the capacity and skill sets of their staff so that they feel comfortable engaging people in addressing physical health issues and connecting them with appropriate resources in the community, whether that be physical health professionals or other services. So I realized both behavioral health home and home care have the word home in them. And home care is often called home health, so it's certainly easy to get confused. But the behavioral health home practitioners really are billing for the services that they would always deliver. So they're not really delivering a different service. It's really trying to enhance the focus and skill sets of the individuals delivering the service. The one incremental, and maybe this is what you were referring to, is I did talk about the fact that we embedded nurses within the agencies to focus on physical health and wellness. And we're paying the agencies for those using a different value-based payment models. So essentially, if the agencies reach certain metrics around screening, engagement, or otherwise addressing physical health issues, then they're eligible for funding to support the placement of the nurse within their agency. So I hope that answers the question. I'm certainly happy to talk offline too if there are further questions about that.
Thanks for that clarification, Dr. Schuster. We have one additional question here, which is, can you speak a little more about how social determinants of health interact with and or complicate each other?
Sure. So there have been a number of studies that have looked at the relative contribution of people's underlying genetics, the physical health treatments they receive, and their social determinants of health, or essentially their environment, as contributions to their overall health status. And what's been found is that genetics probably contribute around 25 or 30% of the underlying health status of someone. So obviously if someone's got a gene that leads them to develop multiple sclerosis at an early age or develop cancer at an early age or what have you, that's a significant driver for those people, those individuals. And clearly, but that's not the primary driver for most people until they reach, near the end of life. They've also looked at the impact of different treatments people receive. And clearly, if you have a severe illness, a cancer or severe cardiac illness, the treatment or a severe substance use disorder or bipolar disorder, the treatment you receive can have a significant impact on your outcome. But that's only for individuals who have those serious disorders. Unfortunately, most of us don't have those in an acute phase most of the time. So it looks like the biggest contributors to our overall health are what you're referring to as social determinants of health. So whether or not we get enough food to eat, whether or not we're fortunate enough to have stable housing, whether or not we exercise, whether or not we get enough sleep, whether or not we have support, good social relationships. Those items all together are the most important predictors and drivers of our health status throughout most of our life. And those also are things that predispose us to more severe illnesses or not. So if you look at the the lifespan of people in the United States, in general, people who are fortunate to have higher incomes and live in more stable and nicer housing settings and have more social supports and probably on the whole less work stress, have significantly longer lives than people who are poor. You know, there was a study that came out now over a decade ago that indicated that people with serious mental illness and substance use disorders have significantly shorter lifespans than the general population. And that's true. However, when you dig down into that data, the biggest driver for many of those individuals was not the presence of their serious mental illness or their substance use disorder, but the fact that they were impoverished, often as a result of the mental illness or substance use disorder. So it really is these social determinants of health that are the biggest driver of health. And so that's why there is so much attention now, appropriately, focused on those themes. And, you know, I kind of feel like to some degree it's, you know, in the behavioral health world, right, we've been focused on where people live and who they live with and what their social relationships are now for decades. And I think, you know, we've now been successful in sharing this theme and having it recognized throughout, you know, medicine and beyond. So fortunately, it's become a really important focus of healthcare more broadly.
Thank you, Dr. Schuster. That was our last question from the attendees. We want to thank you so much for your time this morning, Dr. Schuster. I know I learned a lot during this presentation, and the questions were very engaging. Okay, welcome back, everyone. Thank you so much for sticking with us, and thanks for joining us for our second presentation. A quick reminder to our attendees that this symposium is being recorded, including the chat and question and answer sessions. And with that, I am excited to introduce our next presenter, Colleen Hughes. Colleen is the Executive Director at Westmoreland Drug and Alcohol Commission. She holds an MS degree in Business and Industry Counseling, as well as being a certified advanced alcohol and drug counselor. Ms. Hughes' position involves overseeing the development and implementation of necessary operational activities in regard to the planning, organization, direction, and administration of the drug and alcohol service delivery system. This system includes intervention, prevention, treatment, case management, and recovery support services. She also supervises the use of all funds for the administration and provision of services under the authority of the Single County Authority, SCA. She is a member of the PA Association of County Drug and Alcohol Administrators and on the Board of Directors for Southwest Behavioral Health Management. Her experience includes Deputy Director of WEDAC, Deputy Director and Director of Washington Drug and Alcohol Commission, as well as over a decade of experience in substance use treatment. I'm very excited to have Colleen Hughes be presenting today, Strategies to Coordinate Overdose Prevention Efforts. Colleen, I'll turn it over to you.
Okay, can you hear me now?
We can.
Okay, great. I was like, I need unmuted.
There was a little bit of a delay there. No worries. Thank you so much.
All right, great. I don't need to introduce myself since I had a really nice introduction from Amanda. So I'm going to go ahead and get started. Along with myself, I also have Kathleen McHugh, who is the project coordinator at the University of Pittsburgh Program Evaluation and Research. And Kathleen is going to, we will go back and forth on these presentations. Kathleen and I have worked together for the last couple of years, so I'm very excited for Kathleen to be my partner today. I will be presenting on the Strategies to Coordinate Overdose Prevention Efforts, or SCOPE for short. So by the end of our presentation today, you should be able to describe the SCOPE project and its impact, explain the role that implementation teams have with achieving project goals, explain the role that the Advisory Council has with project oversight, and explain how real-time data collection and feedback loops between project stakeholders supports continuous quality improvement of implementation. Next slide. All right, the scope first result, no. Okay, there you go. Wait a minute, go up again. There you go. The SCOPE First Responder Program aims to train first responders on non-traditional services to better promote the health, safety, and well-being of the people in the system that we serve. This is a 4-year project funded by the Substance Abuse and Mental Health Services Administration, SAMHSA, and the Comprehensive Addiction and Recovery Act, CARA. We will be completing year 2 on September 30th. So before we talk about our approach to achieving the SCOPE project's goals, Kathleen is going to talk to you all about why this work is so important. Kathleen?
Thank you, Colleen. Okay, so what comes to mind when lay people think about emergency medical services, or EMS, as I'll be referring to for the rest of this presentation? So prior to being in this role and working so closely with EMTs and paramedics throughout the state, like most people, my idea of what EMS work was like was mostly informed by medical dramas, if I'm being completely honest. And the media absolutely romanticizes this profession as one that is, glamorous, rewarding, sometimes thrilling, sometimes even romantic, like in this episode of Grey's Anatomy. And while it may be some of those things some of the time, the reality is that most EMS providers experience occupational burnout. And occupational burnout occurs from a myriad of things that are inherent to EMS work. So for one, EMS providers provide care in an uncontrolled pre-hospital setting. That lends itself to repeated exposure to trauma. And there often aren't a lot of resources available to these folks to appropriately cope with their trauma. So as a result, maladaptive coping mechanisms can become lifelong patterns. And we also can't forget that this job is extremely physically demanding. Whether a patient lives on the first floor or the 10th floor, with or without an elevator, EMTs and paramedics are responsible for going into that building, getting that patient stabilized, bringing them down to the ground floor and into an ambulance. And day after day, year after year, that really can take a toll on folks. And organizational stress can also contribute to burnout. So we can see, often poor workplace culture in these agencies and low morale. These folks are working long job shifts, sometimes up to 24 hours at a shift. They have relatively low wages, and as a result, folks are balancing multiple jobs at multiple agencies. And this occupational burnout has impacts on the individual. So psychologically, folks are at an increased risk of post-traumatic stress disorder, suicide, anxiety, and depression. Physically, folks are at an increased risk of obesity, disordered sleep, fatigue, musculoskeletal problems. And these impacts on the individual EMS provider have implications on the field of EMS as a whole. As a result of burnout, we're seeing higher rates of turnover and poor quality care, which really is a public health concern. And this burnout that I'm referring to, it's nothing new for EMS. It's historically impacted the field. However, what is new is that since about 2015, EMS providers find themselves on the front lines of the opioid epidemic because they serve as a major intercept for folks in the community who might not even have access to primary care. So I'm sure most people on the line are familiar with the overdose death numbers in their counties or in their state. And those numbers, while they're staggering, they don't even paint the whole picture of this burden on EMS. Because what they don't show is that for every fatal overdose, there's approximately 20 non-fatal overdoses that EMS are responsible for responding to. And this is only exacerbating the existing burnout that this field was experiencing. And while EMS are on the front lines of the opioid epidemic, they are not equipped with the appropriate tools to respond to it. So for instance, EMS and paramedic education traditionally does not include training on addiction. In addition to not being educated on addiction, the only tool that EMS has is naloxone. And while naloxone is a crucial piece to this puzzle, it gives folks another day, it saves lives, it's not addressing the root cause, which is addiction. So all of this is to say that there is a need for the implementation of expanded services within EMS so we can both equip and empower providers to give patients the care that they need. And now I'm going to hand it back to Colleen to talk about the expanded set of tools that we are proposing for EMS.
So as Kathleen had said, not only are we experiencing the COVID pandemic, but we are still in the midst of the opioid epidemic. So the SCOPE program aims to change the paradigm of EMS practice in response to the opioid public health crisis. So ROSC, which is return of spontaneous circulation, is a pillar of EMS of EMS work. So return of spontaneous circulation is what naloxone does. As we all know, naloxone is a crucial piece of this puzzle. But as Kathleen had mentioned, naloxone is not treatment. The SCOPE program wants to expand on this definition of ROSC to one that encompasses a recovery-oriented system of care. So the goals of the SCOPE program are to provide resources and education opportunities to first responders regarding the opioid public health crisis. It's also to train champions and recruited first responders on implementation of a universal substance use disorder screening question and referral to treatment for eligible patients. In addition, the goals are to provide resources to all overdose patients seen by EMS. And these resources are what are very important for those overdose patients who refuse transport. And then last, we have, they have developed, they being PERU, have developed the trainer model to achieve sustainability post-program funding. So the SCOPE program introduces a public health approach to EMS work through the implementation of a universal screening question for substance use disorders for all patients. And when I say all patients, that's for any call that the EMS have. And the patients, we know as part of the EMS are a major intercept point for patients in the community who may be at risk for SUD. The implementation of a universal screening question allows the EMS to maximize the vantage point they have by identifying patients at risk for substance use disorder, opioid use disorder, and then connecting them to services before they get to the point of overdose. The key is connection to services. This approach can potentially reduce risks by preventing the progression from alcohol and or drug misuse to dependence, addiction, and overdose. This will not only reduce the burden of these substance use related calls on EMS, but it will also, and more importantly, save lives. So the grant allowed us to have as many agencies as we felt we could work with. So we do have 5 EMS agencies in 5 counties who agreed to participate in this project. And as you can see from the slide, we had various different counties in southwestern PA who do participate in the project. So since we're working with several different counties, we needed to have a collaborative team-based approach for implementing this program. So what we did was, with each EMS agency, we had the EMS agency partner with their local single county authority. Then the local SCA serves as the referral destination for the county EMS agency. So when a patient screened positive or was otherwise eligible for a referral, the EMS would connect them with the SCA for services. Some of the lessons learned from this process are that it is crucial for the SCA to have 24/7 capacity. We know, and I'm sure we all realize this, that overdoses and substance-related crises do not happen strictly during 9 to 5 business hours. So it was important that EMS has a number to call at all hours of the day. Also, even though this program is focused on opioid-related issues, we also wanted to ensure that the referral destination, the SCA, could address patients with alcohol and other drug-related issues as well. So it's not just for opioids, it is for all drug and alcohol issues. So PERU provided technical assistance for this project. Part of their technical assistance was working to facilitate connections between the SCA and the EMS agencies. They worked very closely with both the SCA and EMS to understand their workflow and capacity and to develop a streamlined pathway for EMS to make referrals. And I must say, there was a tremendous amount of work involved in making sure that we had this streamlined pathway for the different EMS agencies we were dealing with. So then the implementation teams were developed for each agency. PERU helped to establish and coordinate these teams. The teams consisted of the PERU TA provider, someone from the EMS agency, which was usually the EMS leadership, and then of course the referral entity, which was the SCA. These implementation teams meet on a weekly or a bi-weekly basis. Some of the topics that were covered included discussions on any workforce issues, any changes the EMS agency were experiencing, and increasing screenings and referrals. And I must say that, from the Westmoreland County perspective, we formed a very close relationship with our EMS agency that we probably otherwise would not have. So this is a really win-win situation for all involved. So this is the screening and referral pathway that was developed by PERU and refined as needed, and to again meet each of the county's needs. So the EMS would ask all patients, and again, this was any patient that they received a call on, they would ask the patient the night of single question screening to all responsive non-overdose patients. And as you can see on the screen, this was the question that was asked. If the patient screened positive, they were asked 10 additional questions with the DAS-10, and then they were eligible for a referral. So you're thinking, what are some of the questions from the DAS-10? Well, I'm just going to give you a couple examples, but some are, have you used drugs other than those required for medical reason? And another question would be, and do you use more than one drug at a time? So there's 8 more questions that focus a little bit on drug and alcohol. So patients were also eligible for a referral if there was drug or alcohol indicators present, or if they survived an overdose and refused transport. Once a patient is identified as eligible for a referral, these are the steps that EMS would take to connect them with the SCA. First and foremost, they needed to have the consent signed. So they would have the patient sign the consent, and then the EMS would either call the SCA on the scene if time allowed. And what happens sometime is, they get the patient stabilized, they refuse transport, but they get called out, EMS get called out. So they still make the referral, but the referral could be made off the scene. So now I'm going to turn it over to Kathleen so she can start talking about the technology that was utilized to facilitate all of these steps.
Awesome. Thank you, Colleen. Okay, so like Colleen just illustrated, there were many different patient scenarios, many different screening questions at play. And when we met with our implementation teams and we talked to EMS leadership, they were really excited about this idea and really eager to work with us really in any type of way. However, they were adamant that they could not handle another piece of paperwork on their clipboard. So they suggested that we develop an app for them. So that's what we did. And rather than explaining the app, I'm just going to show you all a brief training video that our training and communications team created that we use as part of training for first responders on how to use this app.
PERU project staff developed an iPad mobile application to seamlessly integrate scope expanded services into EMS workflow. This app was developed based on feedback from EMS providers and is intended to facilitate the various screening pathways and enable quick and simple data collection procedures. By the end of this video, you will understand how to navigate the app and utilize all of its features. As part of the SCOPE program, EMS providers will ask all responsive non-overdose patients a universal drug and alcohol screening question to identify patients who could potentially benefit from local drug and alcohol services. Before the EMS provider starts their shift, they must first sign into the app by selecting their truck, name, and crew members. Let's see how the EMS provider utilizes the iPad mobile application.
So that's just a brief overview of the app. And something that I want to emphasize is that at the beginning of this project, this app did not exist. And we built it alongside EMS providers. So I think that really speaks to the collaborative, innovative nature of these implementation teams. And again, so the app was designed to do 2 things. One, it aimed to make the lives of EMS providers as easy as possible by walking them through every single potential patient pathway. And the other thing that it did was it facilitated real-time data collection. Data that was collected from these apps was sent to our server at PERU, and then we shared that data on a weekly basis with our implementation teams. So this is an example of a weekly data report that we would discuss within implementation teams. As you can see, there's an opportunity for agencies to see how they're implementing in comparison with each other. So that was really effective in moving implementation forwards in terms of just adding a little bit of a competitive aspect to implementation. So again, we reviewed these on a weekly basis, and we really used this data to ensure continuous quality improvement of these expanded services. And we would have open conversations. So if there was a week where it seemed like an agency had a dip in their numbers, we would talk about that and use it as an opportunity to discuss any kind of technical assistance needs. And now I'm going to hand it back to Colleen to talk about project oversight with the Advisory Council.
So as part of the grant, we did need to form an advisory council. And with each of the 5 counties that participated, all 5 of the counties did in fact have a opioid coalition or an opioid task force. So we thought this would be a really good start for us to look at some of the stakeholders. So we have about 30 stakeholders from this 5-county region. We have, of course, the agency, the EMS agency, the leadership, one of their EMS champions, the SCA staff, the case management staff, and of course, PERU for the technical assistants and managers and directors. But we also thought that we needed to have some law enforcement involved. So we have law enforcement on the advisory council, and we also have individuals in recovery. Back up. Okay, there we go. So the advisory council meets quarterly, and as a group, we discuss updates, progress, and any barriers that one of the EMS agencies may have. And it's really great that, you know, another EMS agency may say, oh, it's good to hear what you're doing, and then we're going to try to implement that ourselves. And then also we try to brainstorm on ways to increase staff engagement, and that we also ensure that there is continuous quality improvement. So Kathleen's going to go ahead and give a lot more discussion on some of the data that has been collected.
Yeah, thanks, Colleen. So here is a graph that's showing total patients screened from February 2020 to September 2020. So again, these are all the patients who received that NIDA single question screen among our 5 implementing agencies. And while I mentioned that we typically look at this data on a week-by-week basis, it's also really important to look at these trends over time. As you can see, there are highs and lows on this graph. And it's important to realize that the agencies that we're working with are complex adaptive systems, and they are, you know, responding to what's happening at the agency level, what's happening in the world. Is there a pandemic going on? All of these things impact implementation, especially when you're working with folks like first responders who are on the front lines of any major thing that happens. So as you can see, we have a steady increase leading up until March 1st. We started the year so strong. And then of course, early March, our first responders, you know, every single day was consumed with a new changing policy in terms of COVID response. So, you know, this is just an interesting thing to look at in terms of time. And here, these are folks who received the DAST-10. So those 10 additional questions, folks who received these questions, again, were either they screened positive to the first screening question, or there were drug or alcohol indicators present on the scene. Again, very interesting trends to look at over time. And here are referrals made from all 5 of our agencies between February and now. And like, you know, these past few months with all of these other figures that we're looking at, there are highs and lows. And like Colleen alluded to earlier, you know, it's so important that we persevere with this work with our first responders, because while COVID has certainly been a challenge, you know, across every sector, hopefully one day there will be a vaccine for COVID, but we can't say the same thing for substance use. And, you know, especially in the current climate that we're in with, you know, how uncertain things are, I think that really calls on the importance to, you know, be screening these patients, connecting them to services during this time. And then here we're looking at the total raw numbers since the very start of this project. So March 2019 was when our first agency started implementing. I think that these numbers really need to be celebrated. with everyone involved on this project, especially the advisory council and those boots on the ground staff who are getting this work done. So the fact that 16,539 folks were screened for substance use disorder, I think is absolutely outstanding, especially because this work has never been done in EMS before. And something that I really want to highlight is the fact that of all of those folks screened, 238 received a referral. And another thing that I want to highlight about the nature of our implementation teams and the communication that we've helped to facilitate with these relationships is the fact that we've had the opportunity to make connections between folks at the drug and alcohol case management and at each EMS agency. So folks at drug and alcohol case management are able to report back, what happened with a patient who accepted a referral. So just one example I'll give you from one of our agencies who started implementing in August of 2019. They made 51 referrals to Westmoreland Drug and Alcohol Case Management. And of those 51 referrals, 28 were connected to services. And again, on a weekly, monthly basis, Westmoreland Drug and Alcohol Case Management was communicating those wins back to mutual aid ambulance service, which really helps to motivate folks on all ends of this project. And I would be remiss if I did not give acknowledgement to all of our partners who have worked with us through our pilot program that was funded by the Hillman Foundation and those agencies, and all of the agencies that are working with us on this current project, as well as our partners at Connect Community Paramedicine who have worked to really make our training effective. And that's everything that we have for you all. I know that we are probably a little under on time, so we, of course, welcome the rest of this time to address any questions.
Thank you so much, Colleen and Kathleen. We really appreciate this presentation. I do think, and I also just wanted to share, I can see that there's sharing of contacts and resources in the chat, which is so heartening to see. So thank you to our attendees for being open and still finding ways to network, even though we've moved this symposium from an in-person experience to a virtual experience. So that's fantastic. Here is one question to get us started. Any tips for increasing buy-in amongst less than enthusiastic first responders?
Yeah, that's a great question. Colleen, do you want to speak to that, or should I?
No, Kathleen was really boots on the ground with the EMS when, as she stated, when we started this through a Hillman Foundation grant. And so I'm going to turn that one over to you.
Yeah, so I appreciate that question. And I think that's one of, stakeholder management was a huge part of this project being successful. And I think something that enabled us to be successful was the ability and flexibility to meet each agency where they were in terms of their readiness. So we were able to, assess their capacity, assess their training needs, and really work with them to fill any of those gaps. And that again was also the benefit of working so closely on the implementation teams. We really built strong relationships and were able to have a pretty thorough understanding of where each stakeholder in that county was at, and brainstorm the resources that we needed in order to make them successful.
And then Kathleen, the other thing too was, just to keep them engaged. And this was, pre-COVID, we would look at the number of screenings or assessments that the individual agencies, if there was a particular champion, and we were able to purchase t-shirts. The EMS love to get some kind of incentives, and t-shirts is one of the incentives that they like to get. So Kathleen and I would go and deliver the t-shirts to one of the champion EMS and give them the t-shirt for doing a lot of screenings and referrals that month. So I didn't know, Kathleen, if you wanted to add anything else to that.
And then another thing that I'll add that we mentioned, facilitating that relationship between drug and alcohol case management and EMS so that they could, communicate independently of PERU serving as that middleman to say, hey, that referral you made last week, I reached out to them and this is how they're doing now. It was really and continues to be important to us with this project that we don't want to leave people in the dark of the outcome of the work that they're doing. So we find that, folks on both ends really appreciate that.
Thank you, Colleen and Kathleen. There was a clarifying question in the chat earlier in your presentation. Someone had asked, what kind of prescribed drug would be for non-medical purposes?
The question is, have you used drugs other than those required for medical reasons? So there, I may have misstated, but it's basically as part of the DAS-10, have you used drugs other than those required for medical reasons?
Thanks for that clarification, Colleen. There is an additional question here. It says, do you ever think the position of a certified recovery specialist would ever be a possibility to ride with the EMS?
I don't want to speak for our EMS agencies, but I think absolutely. I've done a lot of ride-alongs in order to, observe workflow and brainstorm ways to be effective with implementation. And I have also done those ride-alongs with case managers. And my experience working with EMS, they're always so excited to have new folks along to show them what they do every day. So if you're interested with that, Joanne, please reach out to me and I'll see who I can connect you with.
And I do know that part of our, we have what we call through our case management unit is the community engagement team that works directly with our mutual aid EMS. And part of that team are 2 case managers and a certified recovery specialist. So he has gone along with them.
Fantastic. Thank you, Colleen and Kathleen. We have another question here. Let me pull it up. It asks, what growing pain would you be able to share with those of us interested in potentially creating something similar?
Growing pain. So I will say that, systems transformation does not happen overnight. And ultimately, that is what this project aims to do. So I would just advise, to be patient, to, whatever agency is interested in broaching this kind of work, to meet them where they are, to make sure that their staff are trained on not only what are we implementing, but why are we implementing this? We put our agencies through a minimum of 4 hours of training, just providing background on what addiction is. And while maybe that wasn't their favorite training to sit through, and we really felt it was important to give them the full scope, no pun intended, of what we're doing and why it's so important and the potential impact that they can have as first responders.
Well, and too, Kathleen, I think that in Dr. Schuster's presentation, there was, he talked about stigma, and as we know, there is stigma even in the EMS field. So when we first started doing the trainings, it was a buy-in. We had recovery people that were that were revised by EMS come and speak during this training to say, hey, you saved my life. And so there were, I think that was a lot of eye openers for some of them, but it is still working with stigma, doing a lot of education. And then again, the reinforcement of us giving those that information back to them saying, hey, of these referrals you made this month, 5 of them are still in treatment. So that's a good buy-in. But those were some of the growing pains.
Thank you. We have a couple more questions here. The next one is, any suggestions for how to build awareness of first responders as resources for those with substance use disorder, rather than first responders being someone individuals avoid?
Kathleen, I think when we talked earlier, what's so important, and again, Kathleen, chime in, is that the buy-in with the EMS knowing the resources. And I think I even said that on my slide. They need to know that there are a lot of resources out there, especially for those individuals that, refuse to transport, and then, maybe later in that day, they have the same person that overdosed again from the transport. So I think working so much with them, developing, handouts, flyers, information so that they can give that to the individual, letting the individual know where they can go and get the help, getting the teams together with CRS case managers, helping to engage. One of the things we did not mention as part of this grant is also the EMS do leave behind naloxone. So, or we did mention it, but we didn't go into a lot of detail about it. And the leave behind naloxone kits also have information in there for where they can go to get help. Kathleen, was there anything else you wanted to add?
No, Colleen, I think you answered that really well. Just facilitating all of these community relationships. I think it's really important that EMS or first responders are not viewed from the community members as, working within their own silo. I think it can really work to help folks feel more safe, comfortable with that population if they see, oh, they work with my treatment provider. And, the person, my CRS actually has done a ride along with that agency and told me that they were really nice to them. Like, I think all of those big and little things help to build those community partnerships.
Thank you both. Here is an additional question. It is, are there any trainings for first responders on substance use and how to help individuals with a substance use disorder?
Hey, Amanda, that's a great question. So we're really excited. This project it's evolved, and it's really been through 3 different iterations at this point. So we started with a small pilot program. We have this larger 5-county grant, and PERU actually is now working on a scope statewide project. So we are responsible for training 33 counties across the state in essentially the same curriculum that our agencies that we presented on today went through. And we also have partners at St. Joe's who are responsible for the other 34 counties. So if anyone is interested in this work, please reach out to me, and either Pitt, PERU, or St. Joe can get any agency in your county trained on this. And I also want to include that project is not just focused on EMS, but also law enforcement, parole, probation.
Thank you, Kathleen. We appreciate all of that information. And if attendees would like additional information about that, please feel free to reach out to us at PERU. We'd be happy to make sure you're connected. I did also want to share, this isn't a question, but there were a number of comments in the chat about how excited people were to hear about this project, positive things that are happening, that there's recovery testimony as part of, and recovery specialists and people in recovery as part of the advisory council. So that pops up several times in the chat. So thank you so much for sharing this really fantastic work, and really making sure you're looking at it from all angles. Know that the attendees appreciated that. All right, well, thank you to all of our presenters today, and thanks for our attendees for the engaging questions. I hope you found this morning to be useful. I would like to let you know that the link to the evaluation will be placed in the chat. In addition, we'll be emailing the link as well as next steps for continuing education credits. Those of you requesting continuing education credits can expect those in the next few weeks. Also, we have links and information about the CEs on overdosefreepa.pitt.edu. The recording to this symposium will also be housed on there. All right, and before you go, we did want to share a webinar series that kicks off next week and is hosted by one of our partners, Vital Strategies. The webinar series runs from September through next spring and focuses on harm reduction. We hope you'll consider joining. And with that, we will be closing up the morning. We hope to see you tomorrow for day 2 of the 2020 Symposium, Building Bridges, Community Partnerships to Mitigate Opioid Overdoses. Thank you so much for your time this morning. And the registration, just to let you know, the registration for tomorrow, if you haven't registered, will be open until 4 today. So you still have the opportunity to register for tomorrow. So thank you so much, and we hope to see you tomorrow.